Morning. Today, I'm going to present a case of 58 years male who is resident of Jaipur and businessman by occupation. He presented with the chief complaints of dysphagia for 2 years and regurgitation for 6 months. The patient was apparently well 2 years back when he developed insidious onset dysphagia, which was intermittent, more to solids initially, for which he had to take extra water with meals to swallow. He had dysphagia for liquids occasionally for the same duration. He had no pain on swallowing, not associated with sensation of choking, coughing, or nasal regurgitation. He also complains of regurgitation of undigested food in mouth for past 6 months. There is a history of significant weight loss, that is 8 kgs in past 6 months. There is no history of loss of appetite, no history of retrosternal pain, burning sensation, or dyspepsia. History of recurrent use of PPI after which he was not relieved. There is no history of hematemesis, melena, no history of recurrent cough, dyspnea, fever, or hoarseness of voice, no history of corrosive ingestion. Past history. Patient is a hypertensive for past 15 years, for which he is on regular medication. He also has diabetes for the same duration, for which he is on oral hypoglycemic agents. There is no history of any cardiac disease, TB, or asthma, and there is no past surgical history. Treatment history. Patient consulted ENT specialist for the same complaint multiple times and was advised for taking proton pump inhibitors, after which he was not relieved. He underwent upper GI endoscopy 15 days back. No biopsy or any therapeutic procedure was done. Also, an upper GI contrast X-ray was done. Personal history. He is a non-smoker, non-alcoholic, vegetarian by diet. He has normal bowel and bladder habits, and family history is not significant. To summarize, uh, my patient is a 58 years male, known hypertensive and diabetic, presented with dysphagia for 2 years, intermittent, non-progressive, along with regurgitation for 6 months, with significant weight loss and no loss of appetite and no chest pain or dyspepsia.
What is your diagnosis thus far?
Uh, Sir, for my first differential diagnosis, I've kept achalasia cardia. Uh, Second is, sir, benign tumor of esophagus or G junction. So third differential is esophageal diverticulum.
Wouldn't the benign tumor at the lower end of the esophagus have been seen as a bulge in the endoscopy? Endoscopy was done recently, so they would have seen that. Also, if they had done a retroflex view, they would also rule out pseudoachalasia because of carcinoma of the esophagus.
Yes, sir.
That's why I asked you this question. You don't always have to give a differential diagnosis. It could be a single diagnosis. In the absence of that, you can say possible corrosive injury from tablets, things like that can be said later. But when a recent upper GI endoscopy, which is satisfactory, for example, from your center, you can then give only a single diagnosis.
Yes, sir. Shall I proceed,
Go
sir?
on. Go on, yeah.
On general physical examination, patient is calm, conscious, and cooperative, and well oriented to time, place, and person. His height is 162 centimeter, weight is 62 kgs, and BMI is 23.62. There is no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. Vitals, pulse rate is 84 per minute. Blood pressure is 138 by 92 millimeters of mercury. Respiratory rate is 16 per minute and afebrile. On abdominal inspection, abdomen is flat, umbilicus is midline inverted, no visible dilated veins, sinuses, scars, no visible peristalsis, no visible fullness in the abdomen, hernial orifices are normal. On palpation, abdomen is soft, non-tender, no organomegaly, and hernial orifices are normal. No free fluid on percussion, and liver span is 14 centimeter in mid-clavicular line. On auscultation, normal bowel sounds are present, and digital rectal examination is normal. On systemic examination, Cardiovascular, central nervous system, and respiratory system is normal examination.
Did you do any cranial nerve examination? Did you do look for nystagmus? Did you look for any auditory problems?
No, sir.
Why am I asking this question?
So it can be a neurological cause of dysphagia.
Yeah, because he's elderly, so he could have pseudobulbar palsy, which could lead to dysphagia.
Yes.
We have still not seen the imaging, so I am saying all these things. You need to take this history. When you do a central nervous system examination and say it's normal, all this should have been done.
Yes, sir.
Yeah, please go on.
There is upper GI and a barium contrast study was done. So I'll like to review that reports.
Have they done a retroflex view based on these images? Can you tell us?
No, sir.
They have not. You're telling me they have not done, or you can't point it out?
They have done, sir. The second column, topmost.
Yeah, topmost image is retroflex. Okay. Okay.
Upper GI endoscopy is showing, sir, roomy esophagus with a bit of saliva in the first image, left side, and there is no signs of esophagitis or any Barrett's metaplasia is not seen, sir.
You did not tell us whether he had visited any foreign nation either for a holiday or for staying there.
सुपरच्या साईडने घाल ना आतमध्ये
Trial. Trial. Trial.
Hello?
Hello. This,
Yeah. Others are not able to hear. There is some disturbance.
yes, sir, there is some external noise,
Trial.
some other
Mic is open.
Yes.
Yeah. Anyway, why did I ask for foreign travel? What is the importance of that?
Trial.
Where especially? Which countries especially?
Sorry, sir.
What is the differential diagnosis for achalasia?
Trial.
Any infective causes are there?
Yes, sir.
Which one?
Trial.
Anybody else would like to answer from the students?
Trial.
So Chagas disease, Africa.
Yeah, that's correct. And it's caused by?
Trypanosoma cruzi.
Yeah, that's correct. So it is important to take a thorough history because you never know what surprises throw up. He might have gone to visit his son who is working in Africa, but one bite of the tsetse fly, he'll get infection.
Yes, sir.
Yeah. Please
Trial.
proceed. What other investigations would you like?
So they've already done a barium. Barium.
Show us that. Yeah, interpret it.
So this is the barium swallow. It is showing, sir, dilated esophagus with no peristaltic constriction seen in the body, and there is a distal smooth tapering with a bird beak's appearance at the GE junction level, and the contrast is going into the stomach, sir. There is no complete obstruction.
Okay. So what view is missing here? One more view they should have done. It's missing here.
Trial.
You have to take an X-ray of the stomach in the reverse Trendelenburg position and fill the fundus with contrast to look
Yes.
for any tumors in the fundus.
Yes, sir.
Yeah, so that's missing. Go on. Yeah, we accept what you're saying. You should also mention lungs and long bones, whichever are visible are free of disease, because this could be a carcinoma esophagus and you would have a lung metastasis or you could have a bone metastasis.
Yes, sir.
Neither in your general physical examination nor in the summaries you have mentioned this, because carcinoma of the esophagus can present as varied diseases, especially adenocarcinoma. So you should be mentally prepared and thinking strongly along those lines.
Yes.
So yeah, go on. What would you see if this was carcinoma of the esophagus?
Pardon, sir?
What would you see if this was carcinoma of the esophagus?
Sir, there would have been a irregular filling defect, sir,
Where?
in the distal esophagus, sir.
That is distal esophageal. What are the three types of tumors? Sievert's classification, tell me.
Sir, Sievert classification is for G junction tumors, sir.
Yeah.
It is basically dividing the tumors within the 5 centimeter of G junction. From 5 centimeter proximally to the G junction to 1 centimeter proximal, that is Sievert's one. And
What
from
should be the lower margin of the tumor or the center of the tumor or the upper margin of the tumor should be particular distance from the
it is
G junction? That is the Z line.
epicenter of the tumor, sir.
Yeah, okay.
Yes.
What is Z line?
Red line is the squamocolumnar junction, sir. Of the,
Okay, please go on.
yes.
You are telling us keywords.
Yes, sir. Sievert's second is from 1 centimeter proximal to 2 centimeter distal to the G junction, sir. And Sievert's 3 is 2 centimeter distal to 5 centimeter distal to the G junction, sir. Yes, Sievert's 3.
Yeah. So based on these investigations, would you like to do something or you need further investigation?
Sir, I'd like to confirm the diagnosis of achalasia with an high resolution manometry, sir.
Yeah, that's correct. What would you expect? Has it been done and what would you expect?
Yes, it's been done, sir.
Yeah.
Sir,
Interpret it.
this is the image of HRM, sir.
What is the pressure in the esophagus?
Sir, there is no, sir, lower esophageal sphincter relaxation, which should have been present with the swallowing normally. And there is a pan-esophageal contractions present, sir.
Would you expect contractions or would you expect aperistalsis?
So there are 3 types of achalasia based on the Chicago classification. In the type 1, there is a complete absence of peristalsis. In type 2, there are pan-esophageal contractions with more than 20% of swallows. And in type 3, there is premature contraction, that is spastic contractions of esophagus with more than 20% of swallows. So these 3 kind of images we can get.
Sure.
Nikhil,
So
are
what
you
is this
able to
type?
hear me?
Yes,
Yeah, we
sir.
are able to hear you, sir.
Okay. Sorry, there was some problem at our end.
Yeah.
Yeah, please carry
We
on.
are seeing the esophageal manometry now. High resolution manometry. I'm asking him to interpret it.
So there is no lower esophageal relaxation seen. And there is pan-esophageal contraction seen in the womb.
What is the pressure of the contractions?
Pardon, sir?
Next week.
What is the pressure, highest pressure of the contractions? Why am I asking you this question?
Our highest pressure is this one, sir. This.
There are also situations where what is hypertensive achalasia?
पर वो डेट डिसाइड नहीं हुआ है तो नेक्स्ट वीक में
Sorry.
क्या बनाई
What is hypertensive achalasia? What is hypertensive achalasia?
So the esophageal body contractions are
About how much? above 110 millimeters of mercury.
Yes.
And what is presbyesophagus? This could be presbyesophagus. You are able to see multiple contractions and there is discoordination. And I'll say this is presbyesophagus. What have you got against presbyesophagus?
Sir, in that the LES relaxation should be there, sir.
I didn't get you.
Sir, lower esophageal sphincter relaxation should be there in that. There might
Yeah.
be discoordination, but
Yeah, that will be there. So, which cranial nerves are important in swallowing?
sir, vagus nerve, sir.
Yeah, more than that? Where does the reflex start from? What is the back of the tongue?
Sir,
Glossopharyngeal.
glossopharyngeal.
Glossopharyngeal and recurrent laryngeal nerve are
Yes.
most important in coordinating swallowing.
Yes, sir.
Yeah. Yeah, go on. Next, please. Read the report, what they have written.
Yes. The written, sir, basal esophageal gastric junction pressure is increased, and esophageal gastric junction morphology is type 1.
Mhm.
Incomplete resection of relaxation of esophagogastric junction with a median IRP of 24.6,
Mhm.
and esophageal peristalsis was absent, but there was pan-esophageal pressurization with more than 20% of the swallows, and this is suggestive of achalasia type 2. Sir.
Okay. So
Then-
that is the more common type is the hypotensive achalasia, where the esophagus does not contract, doesn't have a tone and dilates.
Yes.
So what surgically important points did you notice in the barium and the endoscopy that will help you plan whether to do a non-invasive or an invasive procedure?
So the esophagus
What
is
type of esophagus? Tell me about the axis of the esophagus. That's basically what I'm asking. Can you do these procedures in a sigmoid esophagus? Massively enlarged, dilated, sigmoid esophagus. Is it possible to do any of the conservative procedures? And will you expect good relief after laparoscopic Hellas myotomy? You wouldn't. So that is the reason you have to look for what is the report.
Yes.
Yeah, please go on.
So when the barium and the endoscopy were suggestive of achalasia, why
Yes.
should we do the manometry? Why is it essential to do manometry?
So as there are 3 types of achalasia which responds differently to different treatments. Just to prognosticate the patient will need a manometry, and the confirmatory test for achalasia is manometry only, sir.
What does manometry predict regarding treatment? What you're saying is not true. Not tell just the failure rates. Which type would fail with a Hellas myotomy? With an adequate Hellas myotomy also it fails.
So type 3 has a very poor response rate to Heller's cardiomyotomy.
And type 3 is what?
So spastic, sir. It's
That is
spastic one.
hypertensive esophagus.
Yes, sir.
On the contrary, it is the aperistaltic esophagus trying to be treated by myotomy may not always respond, especially if it's a sigmoid esophagus.
Okay.
So your answer to the question should have been that number 1, barium and endoscopy are suggestive, but the diagnostic investigation for achalasia cardia is manometry. And that is why now it is a standard of care that if possible, you should do a manometric confirmation. Second is that it gives you the type of achalasia, which decides, number 1, what treatment would be appropriate for this patient. And number 2, the outcome of that treatment. So you said that in type, which is the type which responds best to either balloon dilatation or myotomy, cardiomyotomy?
Sir, type 2, sir.
Type 2. And type 3, you said the response will not be as good. So what is the ideal treatment? What would you do if you diagnose a type 3 achalasia? So in type 3, because the entire esophagus is
Long.
hypertensive, you have to do a long myotomy.
Yes, sir.
Either you go by the thoracic route and do a long myotomy, or what else is the option? How else can you do a myotomy?
Sir, poems per oral endoscopic myotomy.
Okay, so we will come to that now later. Okay, go on. A few points in the history which I missed initially, that if I remember correctly, you did not elaborate on the progression of dysphagia. That 2 years ago, how much was the dysphagia and what is the status now? Number one. Number two, whether it is intermittent dysphagia, whether in between there has been improvement in the swallowing status, because
Yes.
you have to be clearly describing whether it is a progressive dysphagia starting with solids, going on to liquids and then not even saliva, or is it intermittent dysphagia? Then, as some textbooks say, that dysphagia with certain type or certain quality of food, the temperature of the food, and similarly, you did mention about cough and regurgitation and aspiration, but especially when lying down, especially when taking liquids. So these points, if you mention in your history, then by the time you have finished history, I know that you are thinking of achalasia. So even the negative history at your level, when you say it, it should clearly convey as to what you are looking for.
Yes.
I don't remember whether you described the examination of the chest in detail. In patients with achalasia, in patients with CA esophagus, in patients with any swallowing disorder because of the risk of aspiration, your description of the chest has to be more detailed than in any other case. You have to say whether there are any added sounds like bronchi or crepitations to suggest aspiration pneumonitis. Okay, please proceed. And as I was saying earlier, sorry, I think it did not reach you, that in clinical examination, please do not make rare diagnoses. So don't make a diagnosis of esophageal benign tumor. Don't make a diagnosis of diverticulum. The only way you can diagnose an esophageal diverticulum, and that also a cricopharyngeal diverticulum, elderly patient who complains that whenever he or she swallows, a bulge appears in the neck, which either spontaneously or on compression empties, and it is associated with aspiration. So that is the only situation where you can make a clinical diagnosis of diverticulum. An intrathoracic esophageal diverticulum is not a clinical diagnosis. So in a case like this, where history is quite clear, you should say that my clinical diagnosis is achalasia. It may turn out to be anything else on investigation, but that is all right. Don't make rare clinical diagnosis.
Okay.
Okay, please proceed.
So, I'd like to do a pre-operative workup for this patient to check for the.
That means you have planned surgery?
Yes, sir.
Why surgery? Why not an endoscopic method of treatment?
So there are various methods of treatment, but the Heller's myotomy is the treatment of choice. As
What
the
can you
best.
add in a Heller's myotomy that you cannot add in a poem? And where does this some of this history you're getting maybe implicated in that?
So we can add a fundoplication.
Yeah, that's correct. That's the correct answer. Is that I would like to add a fundoplication once I confirm that the esophageal peristalsis is existent and coordinated. If the esophageal peristalsis is not coordinated, if you do a RAP, you will get dysphagia.
Yes.
So you have to be very sure. Don't say I'll do a RAP and forget all the findings of your high resolution manometry. High resolution manometry is saying there is diffuse and incoordinate contractions.
Yes.
So if you do a Nissen, for example, you would land up in problem. So what is the alternative? You wouldn't do a Nissen. What would you do?
So we can do a partial RAP, sir, whether anterior or posterior.
What are they called?
Sir, anterior wrap is called Dors's fundoplication and posterior is Toupet's fundoplication.
Yeah, that's correct. So, how many degrees of esophagus would you like to cover with the stomach that you have mobilized?
Sir, in posterior wrap, sir, we are covering 270 degrees.
Yeah, okay.
And
You know the
in-
stuff. Let's proceed.
So
Sir, any
what are the-
questions you
what
want
are
to
the-
ask?
What are the options of treatment for achalasia?
So there can be medical management and surgical management, sir.
That's all, medical and surgical.
Sir, endoscopic as well, sir.
So you should, whenever you are asked a question like this, you should mention the options in some sequence. Either go from simple to difficult, go from conservative to interventional to surgical, go from less extensive to more extensive. There has to be some order. So your answer should have been that the options are medical management, endoscopic management, and surgical management. Surgical management could be laparoscopic or open,
Yes.
isn't it?
Yes.
What are the medical options?
Smooth muscle relaxants, nitrates and blockers. They are given in the sublingual form before meals, depending on which agent we are using.
So only smooth muscle relaxants, nitrate,
Yes, nitrates and calcium channel blockers.
calcium channel blockers. Yes. Okay. So why not a medical treatment in this case? That's the simplest. The patient says that I have read that there is an option of medical treatment.
Medical treatment has a high failure rate, sir, and this patient is fit for surgery, sir. So I'd like to offer
Any
him a
patient, if there are medical and surgical options, any patient who is fit for surgery, you will advise surgery. So all peptic ulcer patients are fit for surgery. They should be advised surgery.
No, sir. But sir, in this case, medical management has a high failure rate, sir.
So say that medical management will be a lifelong management, and
Yes,
the response is not very good and failure is very high. Medical management is usually advised in patients who are not fit for other options of management. It is not the first option. The reason is not that the patient is fit for surgery. That is not the reason. Reason is that it is not a good option of treatment as compared to other options.
Yes.
Management. What are the endoscopic options of management in achalasia?
Sir, we can do a pneumatic dilatation, sir, and we can give a Botox injection in the lower esophageal sphincter, sir, and OM or oral endoscopic myopathy, sir.
So why not Botox?
So Botox is also used in the patients who are not fit for surgery, who are high
It is
risk.
not a-
What is the pressure report here? Didn't they say LES pressure is near normal?
No, sir, it is 24.6 millimeters of mercury, sir.
What would be the normal pressure?
So median IRP should be less than 15 in normal patients. Sir.
Okay, so it's elevated. So
Yes,
you
sir.
can do Botox. What is the problem with Botox? Anything to do with immunity?
Yes, sir. It is basically a toxin, sir, from Clostridium botulinum.
So, how many injections you require for it to start failing?
Pardon, sir?
How many attempts at Botox injection will you be able to do without immunity to Botox developing in the patient and resulting in ineffective treatment? Usually 2 to 3 sessions, that's all. After that, it doesn't work anymore.
Yes.
And pneumatic balloon dilatation, can you do just with the pneumatic balloon, with a fluoroscope or with an endoscope, or a trans endoscopic balloon you are going to use? Which is preferable and which is superior?
Sorry, sir.
Okay. Anybody else in the audience?
Is it the same balloon which you use for dilatation of a stricture, say, or same pressure?
How much pressure does the balloon give? This is forcible dilatation of the lower esophageal sphincter and not just a balloon dilatation. It's not a stricture that's being dilated. So what you're intending to do is you're increasing the pressure with the balloon until the muscle fibers are disrupted. This is the essential difference between a stricture dilatation and a achalasia dilatation. So it goes up to 110 millimeters of mercury and dilates the lower end of the esophagus. You hold it for 2 to 3 minutes and then withdraw it. What is the sign of a successful dilatation?
So the reduction in median IRP immediately.
You won't do that on the table. On the endoscopic table, what would you look for on the balloon that would tell you adequate dilatation is probably done? They used to say it's a streak of blood. If you see a streak of blood, more than not, it's likely to have been successful.
Okay.
So when you are dilating a stricture, basically it is fibrous tissue. And when you put the balloon across the stricture and inflate it, you see what is known as a waist. So at the site of stricture, the balloon is compressed. Above and below the stricture, the balloon inflates. And then the pressure is increased and the waist disappears. That is the sign of dilatation of the stricture because it is a fibrotic stricture. On the other hand, as Dr. Desai said, here, there is no mechanical obstruction. The balloon will inflate. If you put a simple balloon and inflate it to the pressure that you use for stricture dilatation, the balloon will inflate. So what you need is a high pressure inflation of the balloon because the aim is disruption of the circular muscle, disruption of the sphincter. And it has to be to that extent that conventionally when you read endoscopy texts, the phrase which Dr. Desai said, that the endoscopist sees a streak of blood because the mucosa also gets disrupted and there is a streak of blood. That indirectly indicates that the pressure has been adequate enough to disrupt the balloon. And of course, then you confirm it with a manometric evaluation. Yes. So in this case, why not do balloon first? I am the patient, I say, but why should you do surgery on me when there is an endoscopic option available? And you made a statement that surgery is the treatment of choice for achalasia cardia. Is that correct? Then why should there at all be a debate about endoscopy versus surgery?
So there are upcoming results with good results with endoscopic treatment, but
no, the role of POEM is pretty much established now. There are not many controversies left. The only problem is expense and sometimes failure. And you cannot solve the problem of reflux, which you may have to add in the future in case it's required.
And actually, this problem of reflux and adding an anti-reflux procedure also, the advocates of POEM say that in POEM, since they are going from inside out, their attempt is to only divide the circular muscle. And a lot of POEM endoscopists, they would not divide all the muscle layers, which means that the longitudinal muscle, they say, still remains intact. And that is the reason they claim that reflux may not be as high as in a surgical disruption, because when we are doing a surgical disruption of the sphincter, we are going from outside in. So we encounter the longitudinal muscle first, then we go to the circular muscle.
Yes.
And of course, that is a separate topic in itself for discussion, that what is the comparative outcome of endoscopy, both balloon dilatation and POEM versus surgery. But there are certain situations where one is definitely better than the other. As we discussed earlier, if you have a hypertensive or type 3 achalasia, then neither balloon dilatation will work nor a classical standard cardiomyotomy will work. Either you have to do a long esophageal myotomy through a thoracic route, or in this situation, POEM will be better. Similarly, between balloon dilatation and achalasia cardia, are there some factors which decide which treatment is going to be better in terms of age, gender, pressure, and other parameters? Which patient is more likely or less likely to respond to balloon dilatation? Age, anything? Does age have to do anything? Rajat, am I correct, Ajay, that the younger patients are less likely to respond to balloon dilatation?
What was that, sir? Remind me.
Young male patients, yes.
Yeah, younger the patient, the more the attempts required. You end up causing reflux by the end of the dilatations. And you start developing reflux complications as time passes. You start developing strictures, Barrett's, every other problem. So I think transesophageal balloon dilatation is giving way to POEM. It's only lack of skills that is making them still do a balloon dilatation. Otherwise, if the skills of POEM are spread throughout, POEM is vastly superior to what I call balloon dilatation. And circular fibers are the inner fibers and longitudinal fibers are the outer fibers. And if you perforate both, you get surgical emphysema. So surgical emphysema is an indication of complicating of or a complete esophageal transection by the this thing, POEM diathermy tip. So that's very important. And you need to do water-soluble non-ionic contrast swallow at the end of the procedure to make sure everything is okay.
Yes.
So the other points which you should bring into discussion when we are discussing endoscopic versus surgical management is that endoscopic, especially balloon dilatation, one attempt may not be adequate and you may require repeat attempts. The more sessions you have of balloon dilatation, the higher becomes the risk of perforation. Also, patients who have undergone balloon dilatation, failed balloon dilatation, when you operate upon them because of fibrosis within as well as outside the esophagus, the cardiomyotomy becomes technically more difficult. And it is more likely patients in whom you operate after a failed attempt or multiple attempts of balloon dilatation, you are more likely to open the mucosa as compared to a virgin achalasia cardia. So all these points of discussion you have to bring into pros and cons. And a young male patient with very high IRP, is the outcome of balloon dilatation is likely to be poor. On the other hand, an elderly female with low, not very high IRP is more likely or is likely to have a better response to balloon dilatation.
Yes.
Okay, let's come to the technique. How do you do classical Heller's cardiomyotomy?
So we can do laparoscopic or open, sir. Okay.
Describe laparoscopic.
So first we create a pneumoperitoneum with a.
What about anesthesia position?
So patient is in general anesthesia, sir, with the legs apart position and in reverse Trendelenburg position.
Is there anything special about the induction of anesthesia in these patients?
So we'll need a oral bougie, sir, esophageal in the esophageal position.
Why? That is only if you're not able to visualize the laryngeal orifice.
Yes.
What the esophagus is full of food. What can happen the moment they relax? Upper esophageal sphincter also will relax.
So
They develop massive aspirations.
Yes, sir.
So you have to use a crash induction, wherein you compress the posterior wall, the esophagus transversely so that food doesn't come back by pressing on the larynx. That's one important thing. And second important thing is if you are having any difficulty intubating, you have to use a nasal tube and a endoscope to use it rather than using a bougie, because bougie has its own problems, including disrupting the carina. Yeah, please go on. Sorry for the disturbance.
all patients with achalasia, before you attempt any procedure, whether it is endoscopy or anesthesia, they have to be prepared like a patient with gastric outlet obstruction, because these patients are likely to have a dilated esophagus, which is full of saliva and food residue. So the esophagus has to be prepared with a nasoesophageal tube. And if that is not possible, as an extra precaution, pressing the, I think they press the cricoid or
No, they press the entire laryngeal box.
okay, so to occlude the esophagus so that you prevent regurgitation. And as he said, it is a crash induction.
Yes.
Otherwise, these patients are very likely to aspirate during either endoscopy or during endotracheal intubation. And any operation where there is a special position, you have to mention that even without asking. So you here, when you said legs apart, I'm sure you meant that the surgeon is going to stand between the legs, isn't it?
Yes. Yes.
So that has to be specifically mentioned.
What is that position called? Where the legs are spread, but they are not, the hip is not flexed to 90 degrees, but it's flexed only to 45 degrees.
So, French position.
No, Lloyd Davis position.
But
Yeah, that's the posture you need for endoscopy. Otherwise, the legs interfere with their elbows. You can't do the Heller's myotomy because the elbows are being interfered.
yes.
Yeah, and the calf is supported, and the back and this thing is covered by a air bed, water bed, whatever you want to call it. A heater is required in case you are not using heated laparoscopic air. So a heater is required. So you have to put in a request for a heating blanket. That should not be put below the patient, but above the patient.
Okay.
Yeah, go on.
So then we create a pneumoperitoneum, which is slightly to the left of midline, with a Very's needle or an open technique, with a camera port in same position, in between the umbilicus and xiphoid process. Then we insert a liver retractor, so to retract the left lobe of liver.
You mean your first port is midway between the xiphisternum and umbilicus? Is it so high?
No, sir, it is just above the umbilicus, sir. Supraumbilical position.
2/3, 1/3. It's 2/3, 1/3, and it also depends on the body build of the patient.
Yes.
If it's the ectomorphic body, that means thin, long, lean, then you have to put it higher because that distance is more. While in a mesomorph or a endomorph, that distance is short and it's not much of a problem, even if you put it at the umbilicus, upper border of umbilicus. So it all depends on the bodily habitus of the patient. Also, when if you are thinking of doing an open pneumoperitoneum, again, bodily habitus matters.
Yes.
Yes.
Go on.
We put a Nathanson liver retractor to retract the left lobe of liver anteriorly. And then we insert 2 working ports for the main surgeon and 1 port for assistant for retracting. So we start with dividing the, we start with mobilizing the fundus of stomach and
Position of these ports?
Position is, sir, one is, sir, left subcostal in mid-clavicular line, and another port is, working port is right subcostal mid-clavicular line, sir. And for assistant, we are using a, sir, left lumbar port, sir, in anterior axillary line.
Is it right, Ajay?
I'm not so sure about the retractor port. If he puts it so back behind, the colon will keep coming in the way. Every time he takes out his instrument and puts it back. I think it's a bit more medial. 2 inches or 3 inches lateral and below the camera port.
So when you say retractor port, what are you planning to retract with it?
Stomach retraction.
So stomach.
Nikhil, so as Dr. Desai said, that is for pulling the stomach down when you are doing the myotomy. Because liver you are retracting with the Nathanson retractor.
Yes.
Anything to mobilize the left lateral segment?
Pardon, sir?
Do you want to mobilize the
Do
left
you
lateral
want to
segment or
mobilize
no?
the left lateral segment of the liver or no?
No, sir. It is retracted anteriorly, sir. It gives the whole view of hiatus, sir.
If you mobilize it, what will happen? It will keep flopping on the wound where you are planning to operate. It will keep flopping again and again.
Yes.
This is fixed at one point, and the Nathanson will not work. It will slip through the Nathanson if you mobilize the liver.
Yes.
What are the complications of Nathanson's retractor on the liver?
Sir, it can puncture through the liver, sir, liver tissue.
It can cause lacerations in the liver or ischemia of the distal end.
Yes.
So you have to remember to relax the Nathanson every 1 hour or so for
Yes.
5 to 10 minutes. Yeah, go on.
So that's one difference between open and laparoscopic. In open, most people would mobilize the left lateral segment, fold it upon itself, and retract it with a sponge and hand of the assistant. Whereas in the laparoscopic, if it remains fixed to the under surface of the diaphragm, it is easy to, otherwise it will keep falling down.
Yes.
Yes, carry on.
So we identify the fat pad of gastroesophageal junction and start freeing the fundus of stomach. So after dividing the short gastric vessels, then we divide the gastrohepatic ligament to visualize the right crus of the diaphragm. We mobilize
That is fundoplication you are describing. The first thing to disrupt would be the phrenoesophageal ligament,
Yes.
which comes from the below the diaphragm onto the listing, and mobilizing the esophagus.
Yes, sir. We mobilize the esophagus circumferentially, sir.
Yeah, for that you need to identify the crus on both the sides. Yeah.
Yes, sir. Then we.
Why do you want, when you want to mobilize the esophagus, how much you want to mobilize in this patient?
So we need a myotomy of around 4 to 5 centimeter on the esophageal side, sir. So,
And do you go on to the lesser curve or greater curve, or do you come vertically down, or how? What is the distribution of muscle fibers in front of the at the lower end of the esophagus? Is the stomach longitudinal muscular fibers form a hoop around the lower end of the sphincter.
yes.
So if you take an anterior or if you take a greater curve section, then that sphincter action of that muscle is lost. So you should proceed along the lesser curve for a centimeter or half a centimeter
Okay.
to avoid the problem of inadequate myotomy. How do you know what are the landmarks for adequate myotomy?
So we need to do around 5 centimeter on the esophageal side and 2 to 3 centimeter on the gastric side, sir. The myotomy.
Okay, so what can you expect? How do you know when you are wet? What is the difference between the mucosa of the esophagus and the mucosa of the stomach? The point is, the moment you start transiting, there is submucosal rich blood supply.
Yes.
So the myotomy starts getting filled up with blood slowly. It oozes into the myotomy. In fact, previously, before failure of Heller's surgically was described, they used to do only up to this point. That they don't take 5 centimeters of the lesser curve. 5 centimeters of the lesser curve means half the lesser curve. So I don't think that's advised. Sir, what do you say? I'm not so sure about that.
Yeah.
2
So
centimeter on the gastric side, sir.
Yeah.
2 to 3.
from outside, you have the fat pad. Then once you go from esophagus to the stomach, in the esophagus, there are only 2 sets of fibers, 2 directions, longitudinal and circular. Whereas in the stomach, you start seeing the oblique fibers also. And third point is what Dr. Desai said, that you start seeing these submucosal vessels, which are usually not there in the esophageal submucosa. That is how you. Now there is the debate about whether to circumferentially mobilize the esophagus or not, divide the phenoesophageal ligament or not, the extent of myotomy, especially on the stomach side. So I would suggest that if you want, you can prepare operative surgery session on cardiomyotomy. Also prepare a small note about poem. I will request one of the endoscopy experts also to join. Let Dr. Anand know so that we can have a separate session on management of achalasia cardia.
Yes.
So will you do that?
Yes, sir.
Yes, take some time and then inform Dr. Anand when you are ready. Then I will arrange for both surgical as well as endoscopic experts to discuss all the debates and controversies, the type of fundoplication. And if you could also review the recent literature about this debate of when to advise endoscopic management as the first option and when to go straight away for surgery, especially in relation to the points which Dr. Desai was mentioning, megaesophagus and sigmoid esophagus. So include that also and prepare a operative surgery or a treatment session on achalasia.
Okay, sir.
Okay.
Yes.
So students, you can send me a mail at vkkapoor.india@gmail.com. Write esophagus in the subject of the mail, and then I will send you the chapter on operative surgery for esophagus. Thank you, Rajen. Thank you.
Thank you, sir, very much.
Okay, Nikhil. Thank you very much.
Thank you, sir.